Our board members. Anybody else like to announce himself for Board of Health?
Hi, this is Anne-Marie Hirsch from the Board of Health.
Thank you. The only announcement I have is like best agenda back of are there comments? Yes.
No, could you wait 1 minute, please? Could you wait 1 minute, please? Could you? Thank you. Public comment at the beginning here is for anything that is specifically goes to any of the agenda items. If you have comment on anything else, it should be done at the end. Also, this is public comment, not a question and answer period. It's at the discretion of the board as to whether or not they want to answer any questions. And there is a 3-minute time limit per speaker. I'll announce when you hit your 3-minute limit. Also, before you start, could everybody who wants to make public comment please announce your name and your full street address? Thank you. In that case, if you have, you can come up now. I just want you to.
Hi, I am Joanne Stump from Edgemont. The COVID injections should not be even remotely considered for infants 6 months up to 5 years old. The reasons are as follows. Children have a 99.997% chance of a complete recovery from COVID. These injections are still under emergency use authorization and have not been FDA approved. Nothing distributed in the U.S. has been approved. Comirnaty is not being sold here, and in fact, the FDA has recently stated that future COVID injections will not be formulated on the current EUA formulation. These injections do not stop infection or transmission. New York State Department of Health found their effectiveness after 2 doses to be only 12%. Booster trials never looked at effectiveness. CDC has already acknowledged that children who have received the shot are more likely to get infected with COVID than those who have not received these injections. Children who get the shots are more prone to pericarditis, myocarditis, and hepatitis. According to a recent report, 1 in 1,700 children have experienced myocarditis. This is clinical myocarditis, which is damage to the heart muscle. Heart muscles do not regenerate, and any damage is permanent. Pfizer's own data shows children who have received these injections are 107 times more likely to die from the COVID shot than to get infected. According to the CDC, 75% of American children have already had COVID, and after the Omicron variant, it's probably now close to 90%. On June 11th, the World Council for Health, comprised of 70 organizations, called for a total recall of these experimental injections. This was based on the CDC's own VAERS system, the UK Yellow Card system, the EU UDRA, and the WHO systems, which report on deaths and injuries from these shots. 50% of the reports of these injuries were noted within a few days, and 80% within a week. The CDC VAERS site today indicates a total of 40,000 deaths from these injections. According to Harvard, this is vastly underreported. The swine flu injections were pulled immediately after only reporting just 24 deaths. Dr. Mark Makary, a Johns Hopkins medical professional, states, and I quote, "If you look at the fact that 75% of kids had COVID, as of a CDC study back in February, and Omicron has been ubiquitous since then, 80 to 90% of kids have already had COVID. So we are talking about immunizing those who already are immune for a lot of people. That just does not make sense," end quote. Dr. Malone, renowned immunologist, vaccinologist, and the inventor of the mRNA technology, says there is no rationale for vaccinating the young children. As reiterated in a small
The speaker's time has expired.
Thank you.
My name is Karis Coker, 836 Concord Road, Glen Mills, and I appreciate very much the remarks of the lady before me. I only want to say I, too, am very concerned about the approval of any so-called vaccination. It is only an emergency use authorized injection. It is not a pure vaccine. And even Denmark recently has discontinued the use with great concern for its impact. And there was a recent, perhaps even within the last day or two, court ruling that Los Angeles could not mandate vaccines for children 5 and under. This is an egregious assault upon the next generation. I urge you not to approve it.
I'm Christy Perry, West Wayne Avenue, Wayne. I'm excited about your mission, which in part states that you will promote, protect, and assure conditions for optimal health for all residents of Delaware County. This is amazing because the U.S. is ranked 37th in health of all countries. So I'm wondering what your plans are for assuring conditions for our optimal health. They must be something very different from what we are doing as a nation, yet when I review your programs and services, I see nothing new. Thousands of studies show that the key to good health is a healthy lifestyle. This includes high-quality nutrition from real food like fruits and vegetables, nuts and seeds, greens and beans, exercise, good sleep, a connection to nature and to each other and to a God of our understanding, and living from a place of love. Despite our greatest wishes, man cannot make up for the lack of a healthy lifestyle with modern medicine. Our sick nation
I'm sorry,
is...
excuse me, which agenda amendment does this
vaccination, I'm getting to that.
Okay.
Despite our greatest wishes, man cannot make up for the lack of a healthy lifestyle with modern medicine. Our sick nation is proof. A simple example is that a fresh orange has 10,000 phytonutrients that synergistically create health in the body, and if we think a vitamin C pill makes up for that, we're very misguided. Vaccinations won't make up for a lack of a healthy lifestyle either. I had 16 shots as a child. Today, kids have 69. 56% of kids are chronically ill, up from 12% 35 years ago. It looks like a negative effectiveness to me. Infectious disease isn't the main problem anymore, it's chronic illness, much of which stems from lifestyle issues. So why do you focus on vaccines when they won't achieve your goal? We don't get a headache because we lack aspirin. We don't get a cold or flu because we lack a vaccine. We get sick because we lack health. When we don't actively participate in a healthy lifestyle, our bodies are in dis-ease. They are overburdened with toxins and cannot perform their usual powerful housekeeping healing functions. In order to achieve your mission, why don't you offer to access to services that actually promote health? For example, these two key stakeholders would be great to engage with. Greener Partners, whose mission is to sow the seeds of a lifetime of good health by strengthening community health through food, farms, and education. And Mindfulness Through Movement, committed to nurturing the mental and physical wellness of children by offering school-based mindfulness and yoga programs. Delco doesn't need a new health department that relies on the same flawed, illogical approach of our nation. We need a health department with a vision proven to succeed. The CDC MMWR February report showed that seroprevalence of infection-induced SARS-CoV-2 antibodies from natural infection is at 75%. For kids ages 0 to 11, and they have a 99% survival rate. The kids are fine. Please stop wasting our tax dollars and time here on this topic. Please do not vote yes to vaccinate our children today. Thank you.
Thank you for your comments. Anybody else?
My name's Angela Walker from Radnor. I echo some of what the lady earlier said about the childhood vaccines for 6 months to 5 years old. These are very risky for children, and they're likely to increase risks more so than the adults, as their immune systems are underdeveloped. The pediatric clinical trials were very small, and 140 participants, and didn't detect many adverse events because many of the participants were scrapped off. There are no long-term safety data, and as it's under emergency use authorization, it's an experiment. Are you informing parents their children are taking part in an experiment with an unapproved product that has caused many problems in adults? It's unethical to use coercive pressure and allocate taxpayer dollars to recruit vax squads in this county. There's no way to remove the spike protein from the body once the messenger RNA has instructed the cell's machinery to make it. The synthetic RNA makes its way to organs and induces spike protein production for an unnaturally long time, as long as 150 days in one study, perhaps more. This injures the tissues and causes massive potential for autoimmunity to develop in children. Is this why autoimmunity research is a growth industry? The government has not compensated a single person from injuries from this gene product. Children's immune systems are different from adults. It's inexcusable to put the future health of these children at risk. Innate immunity is formative in children. They need to exercise their immune function by constant exposure to natural infections in order to develop strength and resilience to carry them through life. Their naive T and B cells are trained through repeated natural exposure to recognize and rapidly respond to a wide variety of threats and signals from their environment, and to hone a response that is rapid, durable, and adaptive. The antibody response to spike protein is highly specific, and due to the synthetic nature of its integration into the cell's machinery, it stays around a lot longer than is normal. This leaves the innate immune cells less able to be trained to deal with other threats, leading to a reduced ability to fight off other infections and variants. The shape of the spike protein has similarity to other self-proteins and raises the chances of autoimmunity to develop for life. Other countries are already seeing children that have been vaccinated succumb to relatively benign threats like Rous sarcoma virus, influenza, etc. All other vaccines on the childhood schedule are live attenuated virus. This is a gene product with the potential for integration into the DNA, which has already been documented. Before making a decision for their children, are you telling parents of these risks? They should be fully informed of these risks and the availability of other, more safer treatments. I have not seen this in your information. Notably, some members of this board have ties to vaccine manufacturers or institutions that have
Speaker's
business
time has expired.
finding relationships with them and should declare those interests. Thank you.
Are there any more public comments on the agenda item?
In the United Kingdom.
Could we have your name and
Yes,
street
sorry.
address,
My name
please?
is Terry Bell, Preston Road, Media, PA. In the United Kingdom, 76 physicians sent a letter to the UK Medical Regulatory Agency and the UK government officials urging them to carefully consider the move to vaccinate ever younger children against SARS-CoV-2, citing, among some things, the extremely low risk of this virus to young children, poor vaccine efficacy, and the potential harms of the COVID vaccine for young children. I also have concerns about the COVID vaccines for babies and children. Many healthy young children have already had COVID and recovered. Our immune systems are amazingly efficient. They can evolve and learn to fight viral variants because they are powerfully and divinely made. Many bouts of childhood illnesses provide protection against chronic diseases and cancers later in life. And I wonder, where are we heading? Will we come to the point where we attempt to vaccinate the entire population against every form of illness to the degree that we no longer endure a sniffle or mild fatigue? I, for one, do not want to live my life as a vaccine-dependent person, scheduling myself according to the vaccine schedule. Somewhere in time, we lost the confidence in the healing powers we were born with. There's a lot to be said for sunshine, fresh air, water, healthy food, and exercise. Our immune systems need them for optimal functioning, and let us not forget the benefits of a great belly laughter. I think there's a place in science where science can work respectively with nature. We know a lot, but we have so much more to learn when it comes to our very complex immune systems. I'm grateful for the medical advances science has brought us, but science has also brought us harms, as in the cases of thalidomide and Vioxx, as in the cases of vaccine injuries. Healthy babies and children have their whole lives ahead of them. Parents will do their best to make the right decision, and it should always be their decision, and they will look to you. It should no longer be said that those with a healthy immune system need to have a vaccine in order to be protected. They are protected. They have an immune system. And science cannot gild God's lily of natural immunity.
Any more public comments?
William Dennison, Beatty Road, Springfield. I don't have prepared remarks, but it occurred to me that this is pertaining to COVID vaccinations. 2 years ago, when we were all watching Dr. Fauci every day giving extensive briefings and explaining the disease and all, one thing was missing that I noticed. Sometimes it's hard to notice what's not there. And that was any information, any advice on helping people to fight off the illness and by strengthening their immune system. Our resistance depends on our immune system. And the efficacy of the vaccine, any vaccines, depends on our immune system, but nothing was being said. And at the time before this health board was formed, there was information at the state health department website. Again, I think I saw 1 or 2 sentences on strengthen your immune system, get a little sun and exercise, something like that. So I know that you don't intend to answer questions, but I would encourage you, and I would ask the question, you can leave it rhetorical, but do you have any intentions to inform the public of what they can do? Oh, my mother, one of the reasons it came to my mind was my mother was the first full-time dietitian at Riddle Hospital, served there for 14 years. And at the time, she said how little the doctors there cared or knew about nutrition. I believe the doctors in general have come a long way in understanding nutrition, its importance in with many health aspects and diseases. So the question is whether you have any inclinations to inform the public as a public health board of what they can do, especially diet related, to strengthen their immune system. Thank you. Do you have an answer? Do you have any intentions to address strengthening our immune systems?
Again, this isn't a Q&A session. Thank you.
Well, she said that it's up your discretion. Okay, thank you.
Are there any more public comments at this time? Okay, thank you, everyone. We're going to review the minutes and call for approval if there's any concerns with the minutes from last month, well, 2 months ago. I'm not hearing any concerns about the minutes. Call for approval.
So moved.
Second.
Thank you. The minutes are approved. The next item,
You should take a vote. It was seconded, was it? You need to ask for a vote.
oh, okay. Vote for approval.
Aye.
Are there nays?
Aye.
No, thank you. The minutes are approved. The next item is the board update, operational update by the Health Department Director.
Yes, good evening, everyone. It's nice to see all of you and those in attendance in the audience. You had received what we are referring to as the Board of Health meeting updates. So you get those ahead of time to ask questions, but I did jot down some additional pieces of information that came in after that report. had been provided to you. So under population health in particular, we were talking about testing being available from Personic. And since July 1st, there have been 65 PCR tests conducted there with approximately with 7 positives, leaving a 10% roughly positivity rate. I thought that would be of interest to you because we stood up the testing there in Yaden. And then under personal health, wanting to bring forward some, I'll call them outcomes, more or outputs more than outcomes right now, being that we really are a newly forming public health department, working towards what are we reporting to you as far as our performance. But at this point, we have some outputs that I wanted you to be aware of that are not in that report. So within, these were provided by Administrator Stephanie Reese. So if there are questions regarding any of the information I'll share, she can also answer questions. But as of now in our tuberculosis program, we have active cases 6. And then of the cases we're monitoring, we have latent tuberculosis infections, and there are 12 of those. And 6 are actually receiving what we call our virtual direct observational therapy. We have 3 patients that are on prophylaxis. And our TB clinic will start in Yaden on the 14th. The numbers that have been reported here are from our Chester City Clinic. And in STI and HIV, we decided we would report what our weekly average patients are based on the clinic hours that we're currently holding. We're averaging 6 weekly patients. We will be starting to see patients at the GWH prison on the 6th, so that was yesterday. We've hired a 3rd disease investigator worker within that program. We've also hired a community health planner with disease investigation experience within that program. And we'll be starting the STD clinic in Yaden on the 11th. So we're increasing our clinic hours for that program. And lastly, for the vaccine for children program, the free vaccine for children program, we're averaging 5 patients a week right now through our services that we're offering. We'll be going through our certification so that we should be able to offer into September. And meeting with Keystone Health to offer adult and childhood immunizations, including flu shots and pneumococcal in the fall. We have community health planners that are reaching out to local school districts to plan back to school clinics to have catch up for any students that are behind in their immunizations. And we'll be offering evening clinics starting in September. And that will be available on our county website when we have those established. And then we are also looking to explore offering of shingles or pneumococcal vaccines for homebound patients. So thank you, Stephanie, for adding that additional detail. And I think those are the only additions that I wanted to report to you that were not in the written report provided ahead of time. So at that point, if there are any questions you might have on that report, and the division directors and Dr. O'Mahony are also available should there be questions for any of them.
Time?
Yeah, I do. Melissa, just a few questions. How are vaccines being distributed to, or let me put it another way, is the health department responsible for distributing vaccines to pediatric practices in the county?
So you mean any childhood vaccinations to providers?
Specifically the COVID vaccine.
No, they are able to register and order their own vaccine. So the county health department does not distribute those to providers that are wishing to provide COVID vaccines to children.
Yep, approval through the state for that as a vaccine provider.
That's correct.
Yeah, okay. What about monkeypox vaccine? Is that going to be distributed to the county? I know we're within the state jurisdiction, but has there been, have we distributed any, and is there a need for that?
Great question. So we were having conversations earlier this week, in fact, as early as this morning, with state representatives asking if Delaware County would actually be receiving monkeypox vaccine. And the state is following the CDC sort of algorithm on how they're planning to distribute that. It is a possibility that Delaware County will be receiving some, but it sounds as if it's going to be a small quantity. And per the preliminary conversation we've had, we've not had that written guidance provided to us yet. That vaccine would be utilized for those that we would consider high risk contacts, or those who are actually identified as positive cases of monkeypox.
Hi, Melissa. This is Anne Marie Hirsch.
Yeah.
Hi. I just wondered, I saw in your report that like everywhere, it's a challenge in terms of recruitment and retention, particularly of nursing staff. And I'm wondering kind of what flexibility we have in kind of improving incentives for that recruitment and retention.
Yeah, thank you for the question, Anne-Marie. So we at the Department of Health have been benchmarking off of our neighboring counties. So Montgomery County in particular is doing a larger incentivizing for overall hiring, even outside of the Department of Health, meaning any of their other areas, maybe it's Department of Human Services or even within their county operations. So have been benchmarking with them what types of incentives they're considering. So there are monetary sign-on incentives. There have been conversations around retention incentives, meaning for a year or on an annual basis up to 5 years. We've talked about some flexible scheduling as well to help recruit those that might not be able to do a 9-to-5 type of option. So we have been talking those through. However, we do have to work through the county operations side with human resources on how that would work from a county operations side with human resources. But we have been talking about it, but there's nothing formalized at this time.
Thanks, Melissa.
You're welcome.
I had one more question about the epidemiology report. You indicate that the county health department team closed 425 communicable disease cases in June, and you're following just some of the reportable contagious diseases and will take over responsibility for all on July 18th. Could you put that in context for us? You know, how do those numbers compare with your experience? Is this a volume of communicable diseases that the department can handle with its current staffing? Is it is that a large number in your estimation? Is that a reasonable number? What do you think?
Yeah, thanks for asking the question and for additional context. So for the infectious and communicable diseases, it's really fundamental public health work that's absolutely required. And it may seem maybe not as innovative as we want to be for our 21st century public health model that we're striving for, but this is the fundamental work that really has to be put into place so that we're protecting all of our residents, those that visit here or travel through our community, from infectious diseases that can be sometimes easily transmittable from person to person. And there are roughly about 72 of those that are what are called mandatory reporting diseases. So that's sort of the context of why we have to do the work. To answer your question about us taking on all of that work on July 18th, is if you can imagine, each one of the reportable diseases has their list of questions or processes on how they're addressed for what we call a case investigation. So what we might do for chronic hepatitis C would look very different from what we might do for meningitis or syphilis, or monkeypox as an example. They all look very different. And so staff is in the process of being well-trained, well-prepared, shadowing and working closely with the state to be able to take on that full scope of work. So it's important to know that all of the work is getting done in collaboration with the state health department. Starting on the 18th, we're going to be really taking on all of that work. And so to answer your question, right now the staff is will be able to handle it. They could use some pressure. They could use a little relief from time to time. We're using staff to do some of the case investigation that long-term we wouldn't be. So for example, we may have nurses that are doing that work that in the future, as we have more disease investigators, they would be doing that work with nurses overseeing the work, if that makes sense. So we have some of the higher licensed individuals doing work that really will end up being in disease investigation scope of work. As far as the numbers of reportable and infectious diseases that we're getting, I really was a bit surprised on some of that, primarily because I don't think I was taking into consideration our proximity to our urban centers here on the Eastern Seaboard, meaning New York City, Philadelphia, Trenton, New Jersey, even DC. There's a lot of transient and movement within those urban centers, and that just impacts some of those communicable diseases for us, which also adds a layer sometimes of complexity. So we may have individuals that visit New York City, but then actually have family here in Delaware County. And then we may be following up with infectious diseases that may have showed up while they were here visiting. So the density and the complexity of our geographic location, I think, has exponentially surprised me a little bit on what we are seeing on a routine basis. I hope that helps answer your question, Dr. Brennan, but if not, please feel free to ask me for clarification.
Thanks, Melissa, that's good.
I do want to piggyback on the first question PJ had, Dr. Brennan, regarding the pediatric vaccines. Is the county currently involved with the Vaccine for Children program? And is currently the Yaton site giving out the pediatric vaccines, the routine vaccinations?
Yeah, I'm going to ask Stephanie because I don't want to do any disservice in this area, because I know how hard her team has been working, and she can really speak to the specifics around routine vaccinations, then as well as anything we might be doing within that COVID realm as well. So Stephanie, I'll hand it over to you. Thanks.
All right, thank you, Director Lyon. So good afternoon, everyone, or good evening. So to answer your question, we are participating in a Vaccine for Children program at the Yaton site right now. We're offering our clinics on every Tuesday from 10 a.m. to 2 p.m. And we're going to start beginning to offer evening hours starting in September. For our Yaton site, we just recently filled out the application for them to get certified there to offer Vaccine for Children program there. And that should be underway sometime in September.
Another question I have is the monkeypox testing. Is that being offered in your sexually transmitted disease screening clinics currently?
You go ahead, Stephanie. I'll let you go ahead and answer first, and then I can add additional context if needed.
Yep. So at this time, we're not offering testing for monkeypox. We are taking guidance from the state as to when they are going to, because they've been taking the lead on most of the cases that's coming through and having us support them in that way. But at this time, we're not offering testing, but is a plan for us once the state gives us more guidance on how they want us to proceed with that. And I know Melissa's been in, Director Lyon, been in more conversations with the state regarding that. So maybe you have some more input on that.
Sure. Thanks, Stephanie. And this might help with the workflow and how we would receive maybe what we call a suspect case of monkeypox. And typically and it's showing up in ER or physician's offices, and then they're asking for a consult, which Dr. Lisa Mahoney has been being part of those consults and determining whether testing would be required. And that testing, if right now, if we agree that testing is necessary, that they meet the case definition of potentially being converting from a suspect monkeypox to an actual case, we would then have that testing go to the Bureau of Labs. However, physicians can also order that testing privately and not go through the Bureau of Laboratories. So that's how it's been working right now. And it's been in high and constant consultation with the State Health Department. Dr. O'Mahony, would you like to add anything additional around that?
Yeah, thank you very much, Director Lyon and Stephanie. We are, right now it's a collaborative with the state. And as Director Lyon alluded, basically what we're doing is weighing in on a lot of cases that are popping up in the community. So we have not, but we are preparing to be able to incorporate testing in our STI clinics. And I think that's a work in progress with the state, and all the local health departments are starting to gear up and prepare to offer testing should it be indicated. So, as Director Lyons suggested, there's pretty strict criteria on going through the clinical history and exam and who warrants testing. So we're trying to be very thoughtful about that. There's a lot of rashes that are part of the differential diagnosis of monkeypox. And in fact, it really should be a rare occurrence. That said, the state and the CDC, of course, is gearing up and getting ready with vaccine and treatment so that we can be prepared and hopefully over-prepared for something that won't manifest. But this is where we are, and it's a work in progress that likely our STI clinics will be ready to do testing if indicated.
Thanks, Dr. O. And the one piece I would add is when most everything that we've been dealing with has been what we call suspect cases and have not materialized into actually cases of monkeypox. So I just want to be really clear that it's mostly suspect work that we're doing. And then there's also a contact tracing or monitoring of individuals that may be contacts. Those contacts may have occurred in another location in the state or the country, but they may reside in Delaware County. And then it is then Delaware County Health Department's responsibility to monitor those individuals that have been identified as a contact of another individual that has been positively diagnosed with monkeypox. So I hope that helps too. So that's that additional layer of work that we'll be doing. So the monitoring is so important, very fundamental on how we do the work in public health. It would be similar to if we had Ebola as a concern, someone would get off of a plane potentially from an endemic area, and we might be monitoring them for 21 to 27 days just because of their travel history. And I mean, Ebola is just another example. I just wanted to demonstrate this. This is our real fundamental public health work, which prevents the spread of infectious and communicable diseases in our community. So I'll stop there and kick it back to the Board of Health. Thanks, everyone.
Thank you. Also, what is the health department doing in making, in really communication and awareness of prevention of COVID-19 for the immunocompromised, as well as treatment for people that are high risk for COVID, and positive for COVID and high risk? Is the health department, the clinics helping with getting those treatments?
I'm going to need to kick this one back to Stephanie and or Dr. O'Mahony. I mean, in reality, we don't do a lot of work around treatment. We do more around the diagnosis and then referral. But I don't want to speak to the education that may be happening out of our clinical operations. So either Dr. O or Stephanie, if either one of you want to add additional context, that'd be great. Stephanie, go ahead. Yeah, we both went off camera, so Dr. O, I'll let you start.
Yeah, I think that what we're about is trying to really encourage those individuals who are at high risk to be immunized. But in terms of specific outreach to immunocompromised, Dr. Higgins, we're not really doing that piece. Stephanie, I defer to you as well.
Okay, so just to piggyback off what you said, we're not doing a lot of education around that piece of it. We are doing, and this is when we're running our clinics, we are doing consultations as they're coming in and they're having these questions, but there's no actual outreach that we're doing. And in terms of the clinics, we're not at capacity or at any level able to provide treatment for those folks outside of providing COVID vaccines. I will say our community health planners have been working diligently with dealing with and addressing vaccine hesitancy and reaching out to the communities with that type of information.
Thank you both very much. And the one piece I would add was on a state call earlier this week, and there's been a lot of them, so I apologize that I don't remember if it was just with the directors or if it was at a bigger call. But Allegheny County in particular was reaching out to everyone that had been positively diagnosed, that was 65 and older in particular, and asking them if they'd gone for treatment, what treatment they'd received, how quickly their symptoms had resolved, if they had had any symptoms resolved. And I don't remember the exact numbers, but the numbers were really low on the number of individuals that actually responded to them. And so they were trying to figure out the best way to do this outreach, because the strategies they were using, it wasn't comprehensive. So they may have called like 200 people and like 8 returned a call. But I'm making those numbers up. Please know that it was just very low numbers as far as good responses. So I don't know if that's helpful for the discussion to answer your question, but I'll stop there.
Further questions? I'm not hearing any more questions. Should we have to approve the updates, right? The operational.
No, these are just updates.
Updates.
There's actually
Okay.
no approvals on
Okay, thank you. The next one is the county emails.
Thanks, everyone. This is really more just around a little bit of housekeeping. So as we've been growing as a public health department, the IT department in particular deployed us very rapidly, deployed us quickly with computers and emails and hotspots. And a lot of that had to do with your COVID-19 response in the emergency declaration to do so. And with that, emails were provided to, I believe, all of you. And I think some of that too was it was provided to you prior to the Delaware County Health Department even being formed. So it was how you were being recognized and communicating together. Some of the conversations we've been having with IT has been tightening down emails that aren't used, or for emails of individuals that are really outside the Delaware County or the Delaware County system, not just the Delaware County Health Department. So it was recommended that we consider removing your emails and that use the email of your choice for further communication into the future.
Any questions? Okay. The next update is pediatric COVID vaccinations under age 5.
Yeah, I know that Chairwoman Rosemary Holt had asked for an update. I know this has been something that's very important to all of you to just find out where we are. So we do offer COVID pediatric vaccines, and we offer them for parents that so choose to have their children vaccinated. There is no mandate for children to be vaccinated. It's offered as a service to them. So right now, our first COVID pediatric vaccination clinic for 6 months to those up to 5 years old was held on June 28th. And there were 11 vaccinations administered. All of those patients have been rescheduled for their follow-up doses. 2 August dates for Moderna, September and November dates are for Pfizer. And then additional first dose pediatric clinics are going to be held on the 12th and the 26th of this month. So we've primarily been requesting that individuals register, pre-register, or schedule an appointment for that within the hours that we're offering it. But we're not turning away individuals if they are walk-ins. Any questions? Sorry.
Melissa, you're offering both Moderna and Pfizer. Are you seeing any preference for either Moderna or Pfizer at this time?
I know, Dr. O, I saw you come on camera, so I'll let you answer. Perfect.
Yeah, hi, Dr. Higgins. There is a clear preference for Moderna, and I think because families perceive that vaccine as a faster way to complete the series, because it's just a 2-dose series as opposed to Pfizer being a 3-dose series. And the numbers look a little bit better for Moderna than Pfizer, but we have a clear preference.
Thanks, Dr. O.
No,
No, I don't think we're.
We don't take, again, this is not an interactive question and answer session. There's 2 public comments. You can make your comments during public comments. Appreciate your wanting to participate.
You're asking questions.
They're the board. They're the board. The board is allowed to ask questions. This is a meeting of the board.
What's the purpose for our being here now? Are you serving the public?
Excuse me, this isn't an appropriate time to have this discussion. There is not a question and answer session. We're not taking questions from the audience. We can talk about it after the meeting. Thank you. Go ahead.
Okay. Are there any questions from the board at this time?
No.
Okay, thank you. We are ready to go to the new business. Dr. Taylor, presentation from the Temple intern.
I can just add that I believe there's ample contact information out there about how to contact the board, and you can talk to people afterwards, you can email them. It's just that this meeting isn't the forum for asking questions, other than during public comment.
So thanks, Dr. Higgins. I think Dr. Taylor had indicated that she may have to jump off of this meeting. And from what I can tell, it looks like she may have jumped off. So Brigitte, if you are prepared to do your presentation, I think I'm just sort of doing the intro, like, thank you for all of the work that you've done. I sort of got brought in on this on the tail end. I know I think we had a few small interactions, but with that, I'll hand it over. And if you need technical assistance, I think Sean should be able to help you with any of that. Thank you.
Okay, great. Thank you so much. I appreciate it. And I'm just making sure, it looks like my presentation's up. So good evening, and I just want to say it's really good to be here with all of you tonight. I am Bridget Moran McCabe. I'm a fellow Delco resident and current Temple MSW student, and I worked with Dr. Taylor from August of 2021 through April of 2022 as her intern to understand the landscape of behavioral health services within the county, in parallel to when she, Rosemary Halt, and the consultant Grace and all of you were working to getting the Act 315 up and running. So I look forward to sharing some insights and recommendations with you tonight. I first want to say thank you for accepting this role and enacting the first health department. And thank you to Dr. Taylor for her time and attention towards the creation of this report. So you should all have the executive summary and for this report, and Dr. Taylor has the full report with links and references. And so I'd encourage you to take a closer look as time allows, and I'll be going through things pretty quickly tonight. So as you know, Delaware County commissioned Johns Hopkins to do a needs assessment, which identified behavioral health as a priority need. However, behavioral health did not fall under the mandatory services within the Act 315. Therefore, this internship presented an opportunity to get a jumpstart on the data collection to address the behavioral health once Act 315 was in place and the phase 2 was enacted. So essentially what we did was I was working on things for phase 2, but during the timeframe of phase 1. And so what are the mechanisms that we can use to define prevention and behavioral health and work towards mental health equity as a health department? A quick note here is there's always been a divergence between behavioral and physical health within the United States. Behavioral health has really been seen as from the policy side as a social issue that requires the social policy, and physical health is gleaned through a different lens with the healthcare industry. So the number one thing the health department can really do is promote the alignment of the physical and behavioral well-being and kind of that parity, and fold together both as much as possible, while also understanding that promoting the need for quality care that is trauma-informed and culturally appropriate. So this slide shows the popular public health model of that upstream, downstream, and the ways across these constructs of being either inclusive or exclusionary within mental health. And it's a good way to start to shape this needs assessment outline. So here you can see my method slide, working within the frameworks that were already established by the county, which was Public Health 3.0, the social determinants of health, and health equity, as well as keeping in mind that Delaware County is striving to be trauma informed by 2024. So I really looked at the prevention and promotion of behavioral health using the quantitative, qualitative, and SIMLIT review methods, and found 4 areas of focus, which were the infrastructure, programmatic, service navigation, and data collection. And so the report looks at, the intersections between these frameworks, existing services and systems, as well as how to innovate practices, and can be added to the health department's priorities within behavioral health promotion and prevention spaces. So the first one up is infrastructure. This points to the Public Health 3.0 model of being the chief strategist and creates the spaces where prevention and promotion can best happen. Technology is one tool that can help to support existing behavioral health service providers, as well as the clients that they see. And a community center or centers can provide space for all kinds of different functions. Here we have a little bit of information that I know that is already being worked on, such as the no wrong door approach within infrastructure, as well as the parity that I discussed earlier. The specialty teams was an interesting option. Other folks have kind of looked at this in different degrees of success, but basically allowing for funding for certain agencies that have missions that lend towards, further training that specializes in high utilization or complicated situations, so that the referral system can get streamlined. So for instance, if a person has a behavioral health diagnosis of X, all of those referring know how to refer to a team that specifically deals with X. And that's really different than the catchment area model. And so it would probably be some type of a hybrid approach there. The other interesting suggestion to look into from my findings was a referral system on the back end of all the EMRs that use the Epic. So UCSF put together a really good tool to explain the options and help in the decision making. The Montgomery County Department of Health has explored the Unite Us version. The kind of standard is called Aunt Bertha. And it was interesting because the referrals that are provided, if they're more in line with equity and social determinants, then they'll be utilized more. And here we are shifting over to the programmatic recommendations. So the health department really taking a look at adding the peer-based groups into prevention and promotion work, allowing for the lived experience to drive the impact and outcomes of mental well-being, and really looking upstream at what those programs can look like. So this would be across the life spectrum. So for instance, helping families who are maybe getting their children assessed on the autism spectrum, all the way to, if it's the first encounter in behavioral health services due to a suicide attempt. So just looking at how to fund and train those with the lived experience to really talk to sports teams or youth programs and bring the dialogue to destigmatizing and normalizing thoughts of the early symptomology within behavioral health of anxiety or depression, and to really increase the limitations on stigma and shame that place those in not needing or wanting to access treatment. And then again, within that infusion of behavioral health and physical health, I found a couple of interesting works that are being done within the psychoeducational and health educational front, and it might be a good place for the health department to add your expertise. The two in particular that I've named here are within the HIV space and blood pressure. Specifically going back to that Johns Hopkins report, blood pressure was the most commonly used screening tool in Delaware County. And yet doctors often discuss salt intake or diet and not necessarily stress and anxiety as a controller for blood pressure. So again, infusing that behavioral health piece. And then several colleagues in the Human Services Department also noted that there are not many dry events or activities across the county. Again, as the strategist partnering with communities to engage in meaningful activities for them that are without drugs and alcohol, especially in the evenings, would really support the health maintenance of the many who are in recovery. And the last piece here is around staff programs. So I think that they're just as important as the client-based programs, ensuring staff are trained and supported in their work. They can deal with difficult issues such as self-harm. And I think more importantly, due to our current climate with public health officials in particular, helping those in the field to really articulate and draw the parameters around conflict could be really helpful in that retention and job satisfaction. So here in service navigation is the next big bucket that I'm going to focus on. And this is two sides of the same coin, really interesting hub model that was introduced several years ago through Chelsea, Massachusetts, and it's made its way to Pennsylvania. Philadelphia and Abington are two examples that use the hub model right now, and it's an alternative policing model for high utilization county services and gets multi-agency staff involved in cross collaboration and work to increase the resources and decrease the service need. Another suggestion is to utilize the health department staff to identify, kind of through an auditing type of exercise through the EMRs, for additional screenings that might be potential that maybe the clinicians missed because they don't have the training to really be looking through and understanding how to prioritize who needs screening and who doesn't. And then the last kind of bucket, bigger bucket, is the data collection. Oh, sorry. And I'm sure that we're all aware that the data in Delaware County is currently scattered. And as efforts begin to look at how to pull all of that together in the health department, looking at exactly what should be tracked, and to see the unique opportunity here to consider, what drives all of the other factors. So things like asking contracted and county providers to include the social determinants of health screenings. Also looking at the evaluation of the prevention programs that we're putting in place. I didn't find a lot of data on there actually being a lot of evaluation within prevention programs. And so we would be an innovative driver there. And then collecting data on green space. There's a lot of data out there that connects the behavioral health and well-being with connection to green space. So just wanting to name that, there isn't a lot of actual green space data collection happening, but that can be an effort within the well-being of Delaware County residents. And finally, I wanted to talk a little bit about the limitations for my internship. Because I was doing it before the health department actually began, I didn't really have any centralized data. The initial outreach that I did with the human services staff was centered more on the integration and the understanding of existing services, and not necessarily on prevention. I also had a think tank that I did that we had some technical difficulties. And then, as always, we had the COVID factor where we weren't able to necessarily go into finding people with the lived experience through the clinics. And we intentionally did not focus on youth for this particular needs assessment because of the Healthy Kids, Healthy Schools initiative. So I will stop there with a closing of thank you, and stop sharing my screen here. And thanks for your time tonight.
Thank you. I do have a question. You mentioned about the data collection as a problem for the county, and I would say that's probably a problem for all the counties. And you mentioned about the hub model at Abington, and how are they collecting the data? Are you aware at Abington? Because you mentioned that that's the model they're using.
Yeah, so I haven't actually spoken with anyone in the Abington, department, so it would be through the police department. During my time, I went into and did a couple of sessions with the Philly hub, and did go into a few of their sessions. And the data collection in terms of outcomes is shared as a collaborative process within each organization that is involved in that particular case. So they do individual cases, and I don't know how that larger data gets tracked.
Thank you. Questions from the board?
I wonder if you could elaborate a little further on telehealth. You talk under use of technology, you note promoting telehealth reimbursement with county-funded providers. In the provider community, telehealth has brought tremendous benefits in terms of expanding the availability of behavioral health services. Do you have any estimate of what sort of funds would yield how much increased behavioral health capacity?
So at the time, the laws weren't actually, the reimbursement hadn't really been discussed because it was still when like when I started, there was still a lot of the lockdown pieces that were happening. So the laws have changed already in tremendous ways, even since I was done in April in terms of that reimbursement piece. I think what I was really describing more of is how the county can get involved in advocating for that, and particularly within the behavioral health space, but also creating space for those sessions to happen. So within the community centers, for instance, allowing for some quiet rooms where, there's technology for people that don't have, that are across the digital divide, that don't have, spaces, but maybe also it's too hard or too far to get to the actual doctor's appointments, but they can get to the community center a little bit easier, and someone can help them to get themselves set up with that. So it's more on the infrastructure side that I was thinking about that, and not necessarily on the delivery side of the reimbursement strategies, but allowing for mechanisms where more people can have, internet access in their homes. And how do we create that, and or create systems that are within their community that they can access to be able to attend those appointments a little bit easier.
Could you elaborate just a little bit on the distinction between the Unite Us and the Aunt Bertha platform? I think there are a lot of organizations that use the EPIC electronic medical record that use Aunt Bertha. What are the benefits of the alternative?
Yeah, so there's actually a lot of different mechanisms. The Unite Us is just one of many platforms like Aunt Bertha. So the UCSF link that I used, the guiding tool, really went through a lot of the, a chart of what each one presents. And my understanding from the conversation that I had with the Montgomery County Health Director, Christina Miller, is that it does lend itself more into the social determinants a little bit more than Aunt Bertha does. And so, again, it would be just navigating which one is the best fit, but not necessarily the point of the recommendation is to really see what the needs are within the county and what would be the best recommendation. And that tool was a really helpful piece to that. All of the references and links to some of those recommendations are in the full report. I didn't get them into the executive summary, but Dr. Taylor does have access to that. So Unite Us, my understanding in particular is that they are geared a little bit more towards the social determinants than Aunt Bertha, and that's kind of their draw.
Thanks. I just have a couple more. Under programmatic recommendations, you have bolded peer-based model. Is the peer-based model clinical recovery specialist? Is that what those positions are?
So it is, that's one of them. When I talked to the Human Services Department, all of their administrators as part of my data collection, a lot of them really said how important that peer role was in a lot of different spaces. So yes, within the recovery model, there's also mental health models for folks that come into the hospital after a suicide attempt or something like that. And so it draws on that same premise and that same idea, but within the prevention and promotion space. So kind of rethinking that and being a little bit more innovative and looking at how do we find people with the lived experience to help in the promotion of mental health, breaking down the barriers, behavioral health with substance use, really kind of just reworking that model a little bit to talk about it within prevention and promotion, because that really isn't happening right now. It's identifying a peer-to-peer relationship after an occurrence has happened.
Thanks. And this is my last one. Under programmatic recommendations, combining physical health prevention with BH/MH. In the provider world, we would describe this as integrated behavioral health, and this is more of a comment than a question. But integrated behavioral health in our primary care settings has been enormously beneficial. I mean, the ubiquitous nature of behavioral health issues is such that in almost any setting where you have a behavioral health provider, whether it's a sexually transmitted disease clinic, an HIV clinic, a primary care practice, there you will uncover issues of behavioral health, and having somebody available to get someone into treatment, give them guidance, is really beneficial. And to not have it is a lost opportunity that, most organizations are missing. So to the extent that we can do that sort of thing where we're delivering services, I think would really bring an enormous benefit to the citizens of the county.
I agree. Thank you.
Question.
And it looks like we have one hand raised on the Zoom screen.
Yes, hi. This is Oni. I was just wondering, just in terms of the data collection, as we're thinking about developing those systems out, is there a way that we could think about collecting data that is not just based on race, but on ethnicity, but also on country of birth? And I don't know. I know in other counties, in Philadelphia County, for instance, the health departments have been trying to figure out how to sort of backpedal to start to do that, because when the data is not disaggregated, then it leads to misunderstandings of health issues in certain populations. And so I'm just wondering if there's a way, as we're building out data collection systems, to sort of think about that. Is it asking for country of birth? Is it asking for I don't know, but something that is a little bit more, I guess, teased out to get a better understanding of the needs and the health trends.
Yeah, that's a great point. I think from what I had read and looked at, the social determinants of health, there's a lot of different screening tools that I pulled together as examples that are in the full report. But, a lot of those tools often lend itself towards some subset of that understanding, but I don't remember if there was any that specifically named country of origin. And I think that goes full-heartedly in line with the health equity piece of our health department, right? That we're trying to engage in that equity piece, which means that we need to understand what the inequities are based off of a whole bunch of different factors, to include race and or country of origin. So I appreciate that. There wasn't anything that in my recommendations that named that, but I can definitely see how that would be really important, because that cultural awareness that I talked about in the beginning, and having the quality of care related to the competency and cultural humility, et cetera, that needs to come into play there. So absolutely.
Thank you.
Questions from the board members? Thank you, Bridget. Really appreciate the report.
Thank you. Good night, everyone.
The next topic is division reports.
Yeah, hi. I think we probably handled that mostly up in the operational updates. Though I do want to give Deputy Director Laura Warner just a moment. She communicated to me through a text message that there's additional planning to do treatment information at testing sites. So Laura, I would like for you to provide that information if you don't mind.
Well, thank you again. I'm Laura Warner, the Deputy Director for the department, and it's not much more to go beyond that, but Dr. Higgins, to your point, we feel like it's really an opportunity to get treatment information directly to a population of people that have just gotten a diagnosis. So we want to be able to provide hard copies of all the available fact sheets that have already been developed by the State Health Department and CDC about treatment options, so that patients can bring that to their providers and advocate for that.
You're not providing treatment per se.
No, it's just helping.
Are you making referrals to providers for treatment?
We are not. We are helping facilitate testing in Yaden with Personic, and then we were planning on trying to give this outreach materials at other testing sites as well, so it's available for people getting those results.
Thank you.
You mentioned that you're giving education. Are there any pharmacies right now that are dispensing the treatment in Delaware County instead of referring them directly to a PCP for that treatment at this time?
I don't know that.
Okay.
I don't know, Dr. O, if you're familiar with how treatment is working for COVID cases, but is it directly through pharmacies?
No, I think that if you're talking about antivirals and Paxlovid, that has to come through a prescription through your primary care provider. So we in the health department are not facilitating that in any way, except, potentially we raise awareness for individuals who are at high risk, who contract disease, that, it may be appropriate for them to contact their provider for a prescription. But this has to go through the provider as a prescription.
Doesn't have Paxlovid.
Oh, sorry, there's also, Oni has her hand raised.
Thank you. I was just asking a community member, I think, tried to go to the health center in Yaden the other day, and I meant to bring this to the health meeting, and was told that they were only offering COVID testing and COVID vaccines. Is that accurate?
There are definitely other services at our Yaden centers but what service was the person trying to?
They were, I think one of a family member was ill, and I think and I had mentioned the new health center and to go there. And that was the feedback that I got, that when they got there, they were told that they were only offering COVID testing and COVID vaccines. And I was like, and I said, I don't believe that's true, but I wanted to make sure I brought that up today.
Well, we don't provide treatment, Oni, if it was treatment for illness in general. We're not set up to be a primary care provider, nor will we ever be set up to be a primary care provider. Delaware County really does have robust resources in that primary care prevention area, and public health is all of our clinical services that are being offered and provided is really around infectious and communicable disease prevention and spread. So it's really from the prevention side. So it would be very unusual if we ever have clinical operations that are sort of that stopgap or last resort. The FQHCs really fill that role too. So I hope I'm answering your question correctly, and if not, feel free to engage me again.
So is it correct that that center only offers COVID testing and vaccines? Is that the only service being offered?
Oh, no, there's more services being offered. Stephanie, do you mind just giving a small summary?
So I was just sorry, Melissa, because I just wanted to ensure that I don't know if the staff, I don't know, but that was the feedback that was received, that it was only COVID testing and vaccines being offered there.
No, so we're offering vaccines for children there. Starting Monday, we'll be screening, testing, and treating for STDs. We'll be taking care of TB patients as well. So those are, pretty much the services that we're offering there right now. I'm not sure if this individual is looking for, like an urgent care type of, place.
No.
No.
So I think they were just curious, looking at different, and so they went in there, and so that was the feedback that I got. So I wanted to bring that to the meeting to ensure that, because I don't think they even mentioned STD testing as a service that was offered there. No.
Okay. So hopefully that answers your question.
Yeah. Sorry to spend so much time on it, but that's great. And thanks for the feedback, because we really were having a conversation recently about promoting our services and how we're just talking about it today, this morning. So I appreciate that feedback. We'll work towards better promotion. Thank you.
Stephanie, you mentioned about the STD screening and testing. Basically, you're able to provide oral as well as IM treatment. Are you able to also provide treatment for the partners? And also, are you doing any type of pregnancy testing during that STD screening?
Yes, so we are offering partner services. So in part of our with our DIS workers and nursing there, part of what we are doing with our screening and testing is we're doing case investigation or contact tracing. So anyone that they list as a partner that they've been in contact with, we're reaching out to them too. And we're also meeting with partners to get them tested or screened and treated as well. We do have pregnancy tests available if indeed when our patients are looking for that as well. And that's where we work closely with our maternal child health department as well, just to make sure that, if there's the person that tests positive, that we give them the proper resources to reach out to other areas in the community.
For your pediatric immunization, are you able to, start as young as 1 month of age, or is there any age limit?
So we are starting at 2 months.
Thank you. Yeah, for someone that may have missed the hepatitis B vaccine, but that's very rare nowadays.
Yep, and then we do have our Hep B specialist or a perinatal Hep B nurse who's keeping track of those cases as well and ensuring that babies at birth or soon after are getting their hepatitis vaccine.
Thank you. Are there other questions from the board members? All right, thank you. We could do the budget review now.
Thank you. I'm going to go ahead and share my screen. I think many of you had have received the summary of the budget. And then there's one additional piece I want to share with you all. Are you able to see my budget, my screen? If I could get a yes, that'd be great.
Yes.
Okay, thank you. So this is the summary that you had received, and I'm going to give you some context around it and why we designed it the way that we have. So what you're looking at here is what's called our revenue forecasting. And revenue forecasting in Act 315 and Act 12 comes directly from the state, where HIV and STI or STD is grant funded, immunizations is grant funded, maternal child health, West Nile virus, public health emergency preparedness, CRI is City Readiness Initiative. It is tied to the public health emergency preparedness. Workforce development is also tied to the emergency preparedness. Tuberculosis, ELC CARE stands for epidemiology laboratory capacity. It's the CARES Act component. It is tied back to the pandemic as well through public health preparedness. We have environmental fees anticipated. So the total amount of revenue coming in under different types of funding sources such as grants and or ACT is about a little closer to 9 million, but 8.8 million. So then you can see down below where we're asking for a county match to fit into our administration fund, the personal health fund, environmental health fund, and population health. Interesting, as you look at that, you can see population health fund is significantly less than, say, personal or environmental. Keep in mind, all of the public health emergency preparedness funding is actually falls into the category of population health. So they're being funded very heavily up above in those grants. So the overall budget amount of money that we're anticipating for our July 1 through June 30th fiscal year, roughly $18 million, $294,538. You can see down below, I wanted to demonstrate how this is sort of spread across in the each of the divisions. So administratively, all sources we anticipate it's going to cost about $3.2 million. But we're being subsidized in there about 83,000 for some grants with a county match of 2.6. And then you can see Act 315, 590,000 is what we think that we're going to contribute to our administrative operations. So that goes through each of those, the divisions of personal health, environmental, and population health. Again, I want to point out population health at that 6.5 has a lot of that preparedness and response dollars. They also cover collaboration with epidemiology. Your epidemiology is not a division. It's basically interwoven into all of the divisions. Is there any questions on the revenue? And when I share my screen, I really lose my Hollywood squares on where you all are. So if you have questions on revenue, please let me know, and I'm happy to answer them before I move to the next one.
Melissa, regarding the grant, do they require reapplication and approval, or these are approved already for these the grants that you're mentioning?
Yep, thank you. So the grants that we have agreed to accept and start utilizing those funds to provide services are what we would call they're CDC block grants that come through the state to us, or they come through other CDC funding in general, or allocations that come from the federal government through the state that have to get to local public health departments. So ultimately, these are not competitive grants, is what I'm getting to. Is so there's not a competition. This is what's allocated for local public health when you're established as a public health department. And they would be evergreen grants. Of the ones up above that may not end up being evergreen, ELC CARES may not be an evergreen one. It may have an end date that doesn't continue. Workforce development is likely going to change. This workforce development is really heavily focused on COVID-19 response capacity. The next round of workforce development is more generalized for public health capacity in all of our fundamental public health services. I hope that helps answer your question. Any other questions around revenue? We can always go back to it if you have one. So wanted to describe to you, so of all of the revenue that's coming in and then how it's being applied to each of those divisions, as you can see, of the $18 million that we anticipate operational for the Delaware County Health Department, 14 million is earmarked for personnel, salary, benefits, and overtime, those retention options we talked about. So a lot of that is staffing, which I've said, I'm not sure if you've heard me say it, but we really are a department of people serving people. And then it's broken down into these other larger categories, the remaining money, such as personal protective equipment, operating costs, telephone, gas, electric, contracted services, office supplies, capital, rent. You know, you can read the list of things here. Contracted services in each of those divisions, you know, pop health at 204,000. Keep in mind that public health preparedness, a lot of that gets put into contracted services. Any questions on this piece? I'm going to drill down in some additional details. So, but feel free to ask me questions on this one before I move along.
Any questions from the board? Okay, Melissa, you can continue.
Okay, great. So this summary was to break it down so that you could see across the top of exclusions of grants in certain areas and which ones of those grants, what line items they're actually hitting based on our expenditures. So administratively, we don't have a lot of exclusions of grants. The few areas that you see there, that $83,253, we were able to pay for salary of staff that would be working in grants, in particular around the management of the grants. So we'll be able to bill back individuals' time that work in the grants. I'm going to scroll down where you hopefully can see in the personal health services side, they are more heavily subsidized in grants. So of the 4.5 million, 1.275 is being subsidized. And you can see we're putting 1.1 of that towards personnel, 54,000 towards contracted services. We're having some go towards mileage, office supplies, operational medical supplies, postage. So just breaking down where we would be planning to have those monies be subsidized. In that second column, that should be the the subsidy from the county, so the 2.3 million, and then the Act 315 is the column to the right. So again, you have been provided this. I just wanted to demonstrate to you how those subsidies will be impacting the overall budget, which I'm gonna give you an example in more detail moving along here. And there's population health. You can see again, highly subsidizing grants at 3.9 million. I did get a question from council that had said, you know, does this budget look like it's going to increase year after year, you know, if this is year one? And my answer to them was no. This has been built out for what I'm calling a if I've done all of my homework correctly, done the assessment of where I think we'll need to be for our public health department, this should be a fairly stable budget for the next 5 years. And the actual contribution county match should decrease over those 5 years, because we will then be applying for more competitive grants. We'll be eligible for additional funding that can offset that. So the goal is to have less county contribution overall as we move through those 5 years. But in order to operate, this is what it's looking like right now. Budgeted, and keep in mind, budgets are planning tools. And knowing that I didn't have, years worth of expenditures. Some of these are, I don't love to use the word guesstimations, but some of them are really just estimating what we anticipate. So after our first year of expenditures, we will be able to make those adjustments based on our real spending. I hope that's helpful. Okay, I'm going to give you one example under administration that here in administration where I said there was, there's 83,000 roughly that was allowed to be subsidized. You can see now we're actually capturing $50,000 worth of salary in managers and supervisors from our STD and HIV, where you can see we're capturing that for immunization and West Nile virus. So I've done that for each of the divisions. Personal health has a lot more of those. So you can see where we're now capturing those dollars to subsidize the work that we have to do. So you can see where we're applying that to each of the line items in each of those grants. Okay, I'm giving this to you so that in the future, if you want additional details from me, I can provide those to you. And I have one example that I want to show you. Let's see. Oh, darn it. I need to keep hitting this. Just ignore that. I'm demonstrating my. Let's keep going. This is the one I want to demonstrate. I think TB does a really nice job of demonstrating how much we anticipate the program to cost us to operate, and then how much of it is funded. So tuberculosis diagnosis, screening, diagnosis, and treatment is one of the fundamental public health services that we are mandated to provide. It is a mandate. And so we anticipate that it's going to cost us potentially $389,000 to operate tuberculosis. Now, keep in mind, we have to have a physician in that. We also have to pay for those medications for those that are receiving direct observational therapy. We do receive a grant. That grant is $55,000. So you can see that I'm trying to demonstrate where the local contribution is needing to be applied in order to offer this service in our county. So that's an example of how far we've drilled down to say what is funded to offer that service versus what is not funded. And I've done that for each of them: immunization, HIV, STD, West Nile virus, so on and so forth. So I'm going to stop there and ask if there are questions, and I will do my very best to answer them for you. I really hope that you have found we put a lot of time and thought into this budget. It's really comprehensive, and it's going to function. It's going to function in a way that's going to serve this public health department long into the future, where the budget we had for startup was really 3 chunks of money. I think that was done as operational, startup, and COVID-19 response. Really doesn't have the same functionality that I'm presenting to you here today. So I'll stop talking and ask for questions.
Any questions from the board? Melissa, you could continue.
That's all I had then to present to you. If there were any other things that you needed to see in the budget, I'm happy to do so. Otherwise, I'm going to stop sharing my screen.
Comments from the board members? Melissa, we have no questions or comments.
Well, I did that good. Okay.
Very thorough presentation, thanks.
You're welcome. And please do know at any time, if you need additional detail from that budget, you want reports of where we stand,
I would like to start building that into our standing meetings. So please keep in mind what level of detail you're wanting to see from us on that operational side of the budget. Thank you.
The new business is finished. We're going to go for public comments if there's any at this time.
Bill McIntyre.
Could you need to stand at the mic, please?
Hi, Bill McIntyre, Broomall, Pennsylvania. And looking at the budget, and I have a business background, ran a company in Delaware County for 40 years. And it's really highly unrealistic to think of a 5-year budget that there wouldn't be any price increases, especially with this one word that's pretty prevalent in our business environment and overall environment, inflation. Looking at all those costs, you know they're going to be going up. So again, it may be an ideal, maybe wishful hoping, but the practical reality is you're going to see some severe increases across the board. I was in the staffing business, and the demand for labor and the prices you're going to have to pay will all go up because people need the money to pay for other bills. So again, I would love it, but I don't expect it. The other thing is, like, I'm hearing about grants, and that's great, money given to you, but where's it coming from? And are there any strings attached? What I hear, today or tonight, most of it's been, we're focused on preventative, and that's good. But I was really hoping that we'd be more than a one-trick pony, that we provide other things. And like I said, people would say about health, nutrition, so on and so forth. But I also think it's pretty important that we should be able to direct people that are experiencing symptoms to things other than, well, you should have got a vaccination or you could have been prevented, various treatments. So I'd like to see and hope that we become just more than a one-trick pony. And again, if the grant money, who's it from? And are there strings attached? And does it influence our direction of how the health department's being run? Okay, thank you.
Thank you.
Karis Coker, 836 Concord Road, Glen Mills. We are just emerging from the most unexpected and unusual circumstances over the last 2 years. And we have learned that tyranny can come from health departments as well as monarchs that are out of line. And I want the health department to keep in mind, and all those who are on the Zoom as well, to keep in mind your oath. I assume there was an oath to this office that you hold, but even as a citizen, I hope that you would value that which is our legacy of liberty and in our Bill of Rights and the decisions that you make. And remember individual liberty. That's what made us unique. That's what helped us to prosper. Let's keep it.
Thank you.
Hi, my name is Patty McIntyre. I'm on Cherry Hill Lane in Broomall. And some of this stuff's been said before, but I am outraged that our tax dollars are going for an experimental shot for babies, that it's just not tested. It's just, to me, it's criminal. But the other thing is there's so much panic. All I hear is panic, preventative. Vax. Vax is the only solution. And again, this has been said before. There's so many things that can be done preventatively. What about promoting health clinics of nutrition and exercise, lifestyle supplements? And I say this from experience, since this is what I've done, but also I recently, over a month ago, had what one would call COVID. I never got tested because I don't do that kind of thing. And I had 2 weeks of really bad symptoms. They gradually went away. But my solution was, well, first of all, I slept for 2 days straight. 5 days I didn't eat much and I drank a lot of ginger ale. But the first thing I did was take homeopathic medicines. These medicines are FDA approved. They're not just some hokey, crazy stuff. They work. I've done them before. And I actually did it twice because it was pretty severe. So I didn't have a lot of aches and pains as far as like a flu symptoms go, but I was definitely exhausted. And I couldn't eat, and there was another homeopathic medicine I took for that. And when I could take things, I took supplements the whole time. And I know of a lot of people that said, oh, I went through that and I'm still not through that. I'm through it. I'm done with it. And it took me 2 weeks or so. So there are things that really work. And it's exciting that there are things that really work. And it would be really exciting to see more of that kind of thinking. So thank you.
Yeah, hi, my name's Daniel Murphy. I live in Newtown Square. The University of Pennsylvania was paid $1 billion for licensing technology to Pfizer for their contribution to the COVID vaccine. Penn has a long history of committing medical atrocities in vaccine research and development. In 2018, Dr. Stanley Plotkin of the Penn's Worcester Institute, often called the godfather of modern vaccinations, admitted under oath to committing deplorable violations of medical ethics, including forced experimentation on orphans, babies of prisoners, the mentally handicapped, and over 1 million unwitting victims in Congo when it was under colonial rule. Dr. Plotkin became a multimillionaire for committing these medical atrocities. Penn received over $184 million, of which Plotkin received $6 million just for one of the vaccines that was licensed. Part of his work, he chopped up 76, and his staff chopped up 76 late-term aborted babies, chopped them up into little pieces to see if they could be used to culture viruses for vaccine development. That's a clear violation of the Nuremberg Code, which was established in response to the Nazis' medical atrocities, violating human rights of Holocaust victims by forcing their participation as test subjects in brutal, inhumane medical experiments. The Nuremberg Code states that regarding medical experimentation, the voluntary consent of the subject is absolutely essential. This means that the person involved should be able to exercise free will of choice without intervention of any element of force, fraud, deceit, duress, overreaching, or other ulterior forms of constraint or coercion. And it also calls for a duty for any individual that is involved in, who initiates, directs, or engages in any experiment to ascertain the quality of the consent by these individuals, informed consent, all right? All COVID vaccines available are experimental. The media put out some misinformation that Pfizer's vaccine received full FDA approval, but not one dose of the approved vaccines have been administered in the United States. To date, all vaccines are emergency use approval only, and by definition, they are experimental. The Delco Board of Health has engaged in experiment. In this experiment, you've engaged in this experiment by facilitating the distribution of experimental vaccinations. As such, you are violating the Nuremberg Code, which requires any individual engaged in the experiment to be responsible to ensure that the subject has been provided informed consent. Informed consent means that the subject must be told what's in the vaccines. To date, Pfizer has not provided a list of ingredients.
The speaker's time has expired.
Thank you.
Any more public comments? Okay, thank you, everyone. We're going to adjourn the meeting. Oh, I'm sorry.
I just wanted to say, I mean, previous comments people have made over the months, and none of it makes any difference. You've obviously got a sort of an agenda of the way you're going. Do you actually listen to what anybody's saying here? It's just...
Other comments? Thank you, everyone. We're going to join the meeting for today. Thank you.